trainees. And as part of that role, we've developed over the last 10 years a course specifically designed for trainees in surgery to understand a bit more about urology and prepare for ST interviews. This is a 4-day course with speakers from all over the country.
So I think the Biers Core Urology course is a fantastic opportunity for trainees who have an interest in taking up urology to come and learn about some of the things they may never have heard of. One of those things is andrology, give a really great exposure to some of the topic areas that may never come across in their core training, and also get to meet with other people like-minded where they can exchange ideas and hopefully get a step ahead of their competition when looking at national selection.
It was a great course. I'm currently in my core training, and I felt that coming to the end of the 6 months I've learned a lot here today which would have been useful at the start.
Really helpful. It's consolidated a lot of things that I've known, and it's allowed me to now prepare for my interview and see gaps in my knowledge.
There's been a really good spread of topics, really friendly and approachable faculty.
The hands-on training part, it was also really good. All the consultants and the registrars over there, they were really helpful.
I really enjoyed this course because it made for a really good environment where you were surrounded by colleagues, and day in, day out you were sort of dealing with different topics, and it allowed you to really consolidate what you were learning. It was very well paced as well. Sometimes you can feel inundated at these courses. And you meet friendly people, so you sort of know that this is a specialty you want to pursue.
It was a fantastic course, really loved it. Great accommodation, great food, lecturers were excellent. We had really good knowledge of the keynote papers, which was really good for our registration interviews.
Part of the course is to do Viva stations, so they do outpatients and emergency, and they run through scenarios that have previously been. Really opens your eyes if you haven't been on a course yet, and there's lots of scenarios or extra questions that you wouldn't even consider might come up.
Along with the talks, we run specific sessions helping you look at your portfolio with a view to preparing for the ST interviews.
The portfolio station was really good. It was a great opportunity to sit down and kind of find any gaps in your portfolio and talk through how you might be able to address those.
There's lots of events and courses out there that you wouldn't come across unless you've got these people suggesting them to you.
It's not all work, there's plenty of play as well, and you get to socialise, and you will develop some friendships that will take you through the rest of your career.
Yeah, I'd really recommend this course to anyone with an interest in urology, anyone who's thinking of applying.
CTs or clinical fellows who is aspiring to go on ST3 and get the national training should definitely attend this course. I would highly recommend it.
I definitely recommend this course.
Definitely would highly recommend it.
Definitely recommend it. I'd even consider doing it again.
I think this is a fantastic course. It is designed specifically for you, and I think anybody who is at foundation or core training level and who's interested in urology, this is a must. Hope to see you soon.
Welcome everybody to Challenges in Female Neurological and Urodynamic Urology and Audit Matters session. I'm your chair, Aaron Sahai. I'm a consultant urologist and honorary senior lecturer at Guy's Hospital. We have a fantastic program lined up for you this afternoon. It's essentially going to be split up into consensus document discussion and audit. The consensus documents are been chosen because they're important areas of practice. There's been limited evidence in these particular areas, and we've also thought standardization would be useful. We've generated some recommendations to help UK-based practice, and there's still time to influence the document, so we'll be very grateful for your comments and feedback. 3 consensus documents we'll be discussing are bladder and ureteric injury with myself and Nikesh Thruchel, female voiding dysfunction by Suzanne Biers, and complications of long-term catheters by Richard Parkinson and Asad Ali on behalf of all of our section at FNUU. The consensus documents have followed quite a complex methodology. This is highlighted in this flowchart on the slide. The committee identified important areas of practice where there perhaps was limited evidence or standardization would have been helpful. We generated breakout groups who performed a literature review, key guidelines review, and assimilation of key papers. The documents were then formed and then went multiple rounds of review amongst the breakout groups. This was then presented to the entire FNUU committee, who then revised the documents over 3 rounds, and then the documents were sent out to experts in each field. All the expert comments were then assimilated into the document, and the document was sent out to the entire section of FNUU. Final revisions were made at a recent FNUU meeting on the 22nd of October. And then, of course, we'll be presenting the documents today at the virtual session, and we'd welcome all the feedback so we can make final changes. Eventually, the document will go to Biers Council before planned publication. The other half will be related to audit, and we're going to hear the highly anticipated results of the bladder outflow obstruction audit. Chris Harding will do that. This was a retrospective snapshot audit, and I really feel it will give us a great insight into UK contemporary practice. After that, we'll be hearing from Rob Calvert about renal colic, another snapshot retrospective audit. And having looked at the metrics, this is really going to be a comprehensive data collection. And then Rob's going to tell us about what's planned. But from my understanding, this is going to be, the data collection will be sometime in 2021. So please use the chat and comment interface. If you've got any suggestions for our consensus documents, we'll be very grateful. If you have other ideas for future consensus statements, please do not hesitate to make those suggestions. Likewise, if you have interesting thoughts or plans for audit, please fill in an audit proposal form and send this on to the Biers Audit Committee. I hope you enjoy the session. We'll move straight on now to the first talk, which is the Biers consensus document for the management of ureteric and bladder injury by myself and Nikesh Thruchel. We did choose this area because we thought this will be an important area for all urology. There is information and guidance on trauma, but very little on other aspects of injury or insult. The evidence base is limited. Some urologists may be unfamiliar with managing these problems in the acute setting. We also feel that there's some evidence emerging that brand new or newly qualified consultants may not be entirely comfortable with managing these in the acute setting or have the necessary reconstructive skills. So the methods for this particular consensus statement are as previously described in my flowchart, but specifically, we drew on the EAU and AUA guidelines on trauma. We also referenced the BOAST guidance, the British Orthopaedic Association of Audit Standards for Trauma, the management of urological trauma associated with pelvic fractures. We highlighted some key papers, and we identified an important previous consensus document, although that was around 15 years old. I'll now hand on to my colleague Nikesh Thruchel, who will talk to you about bladder injury.
Good afternoon, everyone, and thank you, Sunny, for the introduction and describing the methodology and how we in the section committee came up with our Biers consensus statement. I'm going to be covering the bladder part of this talk, and Sunny will go on to talk about the ureteric injury part. So bladder injury is thankfully very rare. It comes from abdominal trauma in less than 2%. The bladder is surrounded by lots of bony structures. So when the pelvis fractures, quite common, up to 60% will have an associated bladder injury. The majority of bladder injuries are extraperitoneal, 30% are intraperitoneal, and 10% are mixed. So most of our injuries will come from two areas primarily, trauma being one of them, usually by diagnosis from a trauma protocol CT, which typically will not have a delayed phase to it. So it's very important if you have a higher index of suspicion of that bladder injury that you ask for a formal CT cystogram or a fluoroscopic cystogram. And high index of suspicion may come from mechanisms of pelvic injury, symptoms of retention, of course, anuria or hematuria. So, and then the CT cystogram should then classify the injuries to either intraperitoneal or extraperitoneal or both, and you should also consider the ureters and the urethra. So the Biers recommendation, the clear point here is to make sure that you get delayed imaging to make sure what sort of bladder injury there is, and then classify that bladder injury. If it's extraperitoneal, initial management typically would be catheterization, usually urethral. If you consider an open repair, if it's very large, or if you can't keep a catheter in for whatever reason. And then typically you'd leave the catheter in for 2 to 3 weeks, and then do a cystogram prior to catheter removal. If the extraperitoneal repair does not heal after 3 months, or if you're doing surgery for something else, such as associated bone fragments within the bladder, or entrapment of pelvic bones, or vaginal, rectal, or bladder and neck injuries, then you will need to go back in and do an open repair. The key points is that extraperitoneal repairs, the majority, can be managed by catheterization alone for 2 to 3 weeks, and surgical repair if it's a large defect or any associated injuries. Intraperitoneal injuries or mixed injuries will usually require an open repair, because if you do leave them with conservative management, there is the risk of sepsis, peritonitis, and fistula formation. After open repair, consider leaving a suprapubic catheter in addition to a urethral catheter, as it's not uncommon for urethral catheters to either block or fall out, and you don't want all your good work of stitching that bladder closed to be undone by having no catheter drainage. We know that there is no additional risk to orthopedic pelvic bony fracture repairs if you place a suprapubic catheter. If it's a very small injury and you can get good catheter drainage, then it is reasonable to try conservative management with antibiotics and careful patient observation as long as the patient remains well, but obviously intervene if the patient becomes unwell. Again, perform a cystogram prior to catheter removal. So the Bausch recommendation there is that intraperitoneal bladder injuries should usually require open repair and subsequent drainage with the urethral and suprapubic catheter, and then do a cystogram before catheter removal. The other group of patients we'll come across are iatrogenic bladder injuries. And so management of these bladder injuries will depend on when the injury is diagnosed. Most will be diagnosed intraoperatively. So you will see a visible hole or a catheter, clear fluid in the intraoperative field, or gross macroscopic hematuria, or very rarely gaseous distension of a catheter bag during a laparoscopic procedure. If you're not sure that there is a bladder injury, obviously perform a cystoscopy, consider performing bilateral retrograde ureterograms to exclude a ureteric injury, and you can use methylene blue or do an on-table cystogram. Intraoperative injuries will require a direct repair if observed during laparoscopic or open surgery. And then again, drainage is a urethral catheter and ideally also a suprapubic catheter. There are some small exceptions to this. For example, an endoscopic bladder injury, say a TURBT. Bladder injuries are probably a lot more common than we realize, and we leave patients with a catheter and they usually heal and do well. And then the other types is usually when we do anti-stress incontinence surgery, we use trocars for TVT or pubovaginal slings. Again, those bladders usually heal with decent catheterization. So with the iatrogenic injuries, if it's post-operatively, you would suspect that from hematuria, urine in abdominal drain with high creatinine levels, abdominal distension or an ileus, or elevated serum creatinine. Again, imaging ideally by a CT cystogram, and then you proceed with an urgent open repair depending on the clinical condition of the patient and where the bladder injury is. Going back to our intraperitoneal, extraperitoneal classification. Again, be ideally urethral catheterization, but also consider suprapubic catheterization, or in an unfit patient, consider bilateral nephrostomy drainage. So the key points there for Bausch recommendation is intraoperative bladder injury should be repaired by open surgery. Consider the ureters, consider drainage post-repair with urethral and suprapubic catheters and an abdominal drain. And if it's a very small injury, you may get away with simple drainage, but the majority will require open repair. Occasionally, you'll have significant traumatic hemorrhage with intravesical bleeding from the mucosal detrusor. Occasionally, there will be extravesical bleeding into the pelvis or the peritoneum. And this will be managed, as you know, with hematuria, with cystoscopies and washouts or diathermy. Don't forget to consider arterial radiological embolization can be very useful in this group. If it's significant repair, you may have to do a laparotomy and pack the bladder and ligate the vesical vessels, and very rarely an urgent cystectomy. These are all very, very rare incidences. But the key point is to remember and consider arterial embolization in this group. Of course, occasionally you will come across intravesical foreign bodies, and we would recommend that you remove these ideally cystoscopically, but if that's difficult or not possible, consider open surgery or percutaneous approach through the skin and the bladder, like you would percutaneously approach the kidney renal collecting system. So I'll just touch on some of the principles of open repair, because I think this is something that all urologists will come across in their consultant life. is that a urethral catheter should be in situ, perform a lower midline or fan and steel, and you may use whatever exposure is being performed for the surgery itself. You want to pack away the bowel. You want to have good retraction. I often use an omnitract, which I'm a fan of, because that does all the work for you. You want to debride the bladder to healthy edges. Don't forget the ureters, and then mobilize the bladder so you can bring the bladder together without tension. Place a suprapubic catheter before you close the hole, ideally. And then use absorbable stitches, and I use a single layer full thickness absorbable sutures such as Thruchel. Some people would use a 2-layer closure. The key point is that there is mucosa to mucosa apposition, and then again you can use continuous or interrupted, and I typically would use a single layer continuous closure. And then you want to try and protect the closure, so ideally bring some momentum over the area, and place a non-suction drain. It's very important. Place a suction drain, which does happen sometimes in orthopedic surgery. You encourage a fistula, as urine will be pulled out. And then the other key points is that the catheters must remain on free drainage to allow the repair to heal. And then do a cystogram at 2 or 3 weeks to check healing of the bladder before you remove the catheters. So the key points and Biers recommendations there are adequate exposure, urethral catheterization, mobilize the bladder, close the bladder, how you feel comfortable with, ideally place a suprapubic catheter and leave a drain, and then a cystogram at 2 or 3 weeks before removal of the catheter. So in summary, it's quite straightforward, but the key points are that you'll experience bladder injury with bladder trauma or iatrogenic injury. Depending on the clinical condition of the patient, you will then determine if you can repair it straight away or you can sit tight. Classification is important with CT cystograms to determine whether it's an intraperitoneal or extraperitoneal. Often use, if you can, a suprapubic as well as urethral catheter to maximize drainage with or without repair, and then do a cystogram at 2 to 3 weeks to check the bladder's healed before catheter removal to reduce your risk of having an ongoing injury or fistula formation. Thank you very much.
Thank you very much, Nikesh. We'll now move on to ureteric injury. Ureteric trauma is rare. It affects 1 to 2.5% of all urinary trauma, and that's largely because the ureters in the retroperitoneum are now protected. 80% is iatrogenic, and that's what we will tend to see in our practice, and unfortunately it's often missed. The remaining 20% are related to trauma, 2/3 are penetrating, and 1/3 blunt. Blunt injuries are usually related to deceleration and usually affect the upper tract, particularly the pelvic-ureteric junction, and this is more prevalent when there's anomalies, for example, PUJ obstruction. This slide demonstrates the general management strategy, but it does depend on a number of things, whether the presentation is immediate or delayed, whether there's coexistent injuries and their severity. For the purposes of this document, we've split it up into trauma, perioperative injury, postoperative or delayed injury, and late presentation or ureteric insult. Ureteric trauma should be considered with penetrating injuries in or near the course of the ureter and in blunt trauma with deceleration injuries. We would recommend routine urine and bloods, but the key investigation would be a CT contrast scan with a delayed urographic phase if an immediate laparotomy is not required. If there's doubt, cystoscopy and retrograde studies can be formed, and it's important to examine the bladder and the contralateral ureter. Following definitive repair, whatever that may be, there is usually a stent in place, and this should be removed at 4 to 6 weeks. Further imaging should be undertaken, usually in the form of a mag-free renogram at 3 months, and we recommend further imaging at a year. Here are some examples of what we may see on a CT scan. The things to look out for are frank extravasation, hydronephrosis, free fluid, or ureteric dilatation. You can see evidence of hydronephrosis here, evidence of free fluid in the pelvis here, and on a delayed urographic phase, we are now seeing contrast material clearly sitting behind the bladder. This is some example of some retrograde studies. Here is a ligation injury in the distal ureter. And on this picture, we can see frank extravasation medially of contrast material. The American Association for the Surgery of Trauma, AAST, have a ureteric injury scale, and this is graded on 1 to 5. 1 is a hematoma or contusion, 2 to 3 essentially is a laceration, either less than or greater than 50%, and 4 or 5 is complete transection with either less than or greater than 2 centimeters of devascularization. The type of repair will be dependent on the location of the injury, and we agree with the EAU guidelines on what types of repair should be undertaken depending on location. You can see in the lower ureter, we'd recommend ureteroneocystostomy, direct reimplantation, and this may be facilitated with a psoas hitch as depicted in this pictorial to make the anastomosis tension-free. In the mid and upper ureter, options include ureterosterostomy and transureteroureterostomy as depicted in this pictorial. In the upper ureter, in addition, you may have the option of ureterocalycostomy, and in the mid ureter, the use of a Boari flap. If there's significant ureteric loss, an ileal interposition or autotransplantation may need to be considered. The principles of ureteric reconstruction are clear. Careful mobilization with blood supply, debridement of any necrotic tissue, wide spatulation of the ureter, a tension-free repair over a ureteric stent, the use of absorbable sutures, and isolation of the repair with either omentum or peritoneum, and then placement of a non-suction drain near the site of repair. We move on now to trauma. We would adhere to ATLS principles in the emergency management. Hematuria will be an unreliable symptom and sign of ureteric injury. In unstable patients needing an immediate laparotomy, the ureter should be inspected for injury. In cases of injury, immediate repair is recommended over a stent. However, in certain scenarios, if there's an unstable patient, polytrauma, for example, ligation and a planned nephrostomy with definitive semi-urgent repair is also an option. In all other cases, we would recommend a CT urogram, plus or minus cystoscopy and retrograde studies. If there's a partial injury, a trial of ureteric stenting is appropriate. If there's a complete injury or ureteric stenting risks converting a partial to a complete injury, immediate repair is warranted. On to perioperative ureteric injury. Now, this is the commonest scenario we encounter. Iatrogenic is the commonest mechanism, and they're typically from other specialties such as gynecology in the form of hysterectomy or cesarean section, colorectal surgery in the pelvis such as AP resection or low anterior resection, and urology ourselves. The typical scenario in this case would be ureteroscopy. During ureteroscopy, if there is a significant ureteric injury, the procedure must be terminated and a stent deployed. If this is not possible, insertion of a nephrostomy is recommended. During pelvic surgery, if there's a crush or ligation injury to the ureter, and if it's immediately recognized, this can be released and then the ureter stented. We would recommend in this scenario delayed retrograde study to assess the ureter. In cases where perhaps there's been a long case and the ligation has been long-standing, hours perhaps, it's probably going to be more sensible that the suture is released, the devitalized segment removed, and a ureterostomy performed. In all cases of full ureteric transection, immediate repair is recommended over a stent, and the type of repair will be dependent on the location as discussed in the previous slide. Thankfully, this scenario is rare of ureteric avulsion. If complete and the ureter is delivered whole and intact on the ureteroscope, it can be utilized with a greater omentum wrap and joinings to the renal pelvis and the bladder, i.e. a pyloureterostomy and a ureteroneocystostomy. Alternatives will include ileal interposition, autotransplantation or nephrectomy, and partial avulsion as depicted in this antegrade nephrostogram. The repair will be dependent on the location. For example, in this case, in the upper ureter, a long Boari flap was made. Immediate repair is always preferable, But if there's a lack of expertise available in the local centre, a nephrostomy and drain should be inserted prior to transferring the patient. I put this up because I think this will be useful. This is a useful mnemonic, the 5 Ps, for really managing these types of injuries, whether it be ureter or bladder, in an unfamiliar environment, such as a gynecological or colorectal theatre, or perhaps another theatre in a different hospital. The 5 Ps stand for patient, position, personnel, planning, and procedure. And it's really a checklist of what to do. It's important you speak to the surgeon who's done the case so you can understand the current situation. The surgeon and anaesthetist to understand blood loss, if there's suitable cross-match, for example, available. We need to speak to the theatre sisters and the staff to understand what equipment is there, what you need to bring over, and what they have ready. You're likely going to need a cystoscopy stack, stents, wires, ureteric catheters, and certain types of suture, and an X-rayable table. And this is just a nice little mnemonic from Data et al. Published in the BJUI in 2013 that I thought would be useful. On now to the post-operative or delayed ureteric injury. Signs and symptoms are typically of loin pain, fever, ileus, acute kidney injury, or urinary incontinence in those cases of ureterovaginal fistula. A CT urogram should be utilized to assess the urinary tract and any other abdominal pathology. Cystoscopy and stenting should be attempted, and assessment of the bladder and contralateral ureter. If there's already a nephrostomy in situ, a rendezvous type procedure can be contemplated in select cases. An immediate repair is recommended and can be performed if the injury is recognized within 14 days. However, there would be certain circumstances where this may not be sensible. For example, some patient factors, anticoagulation issues, or a severely septic patient. If greater than 14 days and there's been a failed stenting, a nephrostomy should be inserted plus or minus a drain. A delayed repair at 3 to 6 months should be performed in cases where presentation is greater than 14 days and stenting is not possible, or in those who have developed a stricture despite the placement of a stent at follow-up. Typically, in the case of a stricture which is delayed, balloon dilatation or endoscopic incision is usually not successful as a definitive treatment option according to the literature. The final section is late presentation of injury or insult to the ureter. The insults I'm referring to are radiotherapy, TB, schistosomiasis, endometriosis, and retroperitoneal fibrosis as examples. This retrograde study here depicts a almost corkscrew rat tail appearance of the distal ureter, and this is a ureter that's been caught up in fibrosis and inflammation related to endometriosis. Assessment for this group is again with a CT urogram plus or minus cystoscopy and retrograde studies. But because the presentation is delayed, it may be sensible to get nuclear medicine imaging, classically in the form of a DMSA scan, to understand kidney function. The management of the ureteric injury will depend on this kidney function, the level of injury, and other patient factors. This flowchart is really a summary of what we've discussed to date about ureteric injury. You can see a section on trauma, injury, delayed diagnosis, or less than or greater than 14 days. I will leave up the slide for a few seconds. The final slide talks about prevention of bladder and ureteric injury and when to refer to a specialist unit. Sounds obvious, but during surgery, one can fill up a urethral catheter to distend the bladder, and this allows easy identification during surgery. Ureteric stenting should be employed in high-risk cases to give surgeons tactile feedback of the ureter, but also to identify intraoperative ureteric injury. There have been a number of innovations recently, such as transillumable stents and indocyanine green and near-infrared fluoroscopy, for example, in minimally invasive surgery to highlight ureters and devitalize segments. If no expertise is available in general in the acute setting, temporizing measures should be employed, such as nephrostomy, and drains and stents prior to referral to a specialist centre. Very much like to thank the co-authors of all the consensus documents, essentially the FNUU committee, whose names are highlighted here. And I'm very grateful to Jeremy Okrim, Sachin Malde, Andrew Symes, and Mohammed Shamim Khan, who have acted as experts in this bladder and ureteric injury consensus document. Many thanks. Please do post any questions or comments on the forum. And if there's any other further queries, please do not hesitate to email me at aaron.sahai@gst2.nhs.uk. Thank you for your attention.
Good afternoon. I'm going to be talking about our Biers consensus on the management of female voiding dysfunction on behalf of the FNUU section of Biers. So the FNUU committee decided on important and challenging issues in the arena of female and functional urology, where we wanted to make suggestions of what might constitute best clinical practice. Following establishment of the subject, which was female voiding dysfunction, we performed a literature search which did incorporate existing guidelines and went through multiple rounds of FNU committee review, both individually and as a group. We sought further views of all medical professionals working in the relevant fields, specifically the FNUU membership, and further FNUU committee reviews were convened. We had a formal consensus meeting, and I'm now presenting this at Biers in order to accept comments and suggestions from the entire Biers annual meeting attendees. We aim to refine and revise all these comments into a consensus document that will be presented to Biers Council, with the aim to provide a standardised UK approach to the assessment, investigation and management of female voiding dysfunction. The diagnosis or definition of female voiding dysfunction is that it is diagnosed from a combination of both patient symptoms and urodynamic investigations. And it's defined as an abnormally slow or incomplete micturition based not only on abnormally slow urine flow rates, but also abnormally high post-void residuals, ideally on repeated measurements to confirm the abnormality, and pressure flow studies can be required and often are to determine the cause of the underlying voiding dysfunction. The main causes are those of a bladder outlet obstruction, which can be due to anatomical, neurological or functional etiologies, or detrusor underactivity. Starting with female bladder outlet obstruction, or BOO or BOO, this is defined as obstruction during voiding that is characterised by increased detrusor pressure and reduced urinary flow rate. And the incidence is reported to be between 2 and 23%. And most typically, patients have voiding symptoms, but can also have storage or mixed urinary symptoms, recurrent urinary tract infections, and urinary retention. We propose that there should be a standardised approach to assessment, and this should include a full and focused urological history, gynecological and neurological history, a record of the patient's medications, specifically those that can contribute to underlying underactivity or outflow obstruction, previous medical, surgical and psychosocial histories. Patients should undertake a chaperoned examination of the pelvis, vagina, abdomen and neurological assessment, and urine should be tested for infection with a dipstick, any infection treated and the patient reassessed. Important other investigations or as part of the assessment include a serum creatinine and renal tract ultrasound, particularly important for those patients with high residuals, and a bladder diary in those patients that are able to void. We advise the use of a validated questionnaire, and we have suggested the ICIQ FLUTS, the International Consultation on Incontinence Questionnaire on Female Low Tract Symptoms which is based on the BFLOTS SF questionnaire and comprises of 12 different items where patients are asked about symptoms and the bother of those symptoms, including storage and voiding symptoms, as well as incontinence. We recommend basic urodynamics, starting with uroflowmetry and post-void residual testing. And as a rule of thumb, it's felt the criteria for avoiding dysfunction are where there's a maximum flow rate, or a Qmax, of less than 15 mils per second, and or a post-void residual of 50 mils or more. Although in clinical practice, we appreciate that more significant or higher residuals are often found of over 150 mils. Video urodynamics is important to the diagnosis of female bladder outflow obstruction. It provides a dynamic understanding of the condition and also gives us a clue about the underlying etiology and location and level of the blockage or obstruction. In female bladder outflow obstruction, the findings tend to be that of a high detrusor voiding pressure and a low urinary flow rate, or the patient is unable to avoid at all. And these fluoroscopy images show some typical findings that you might expect to see. So in figure A, we have a bladder neck obstruction where there's a pinching off or closure of the bladder neck during attempts to avoid. Figure B is looking at obstruction at the level of the urethral sphincter. So there's a ballooning or dilatation of the proximal urethra and then nipping in of the urethra where it's contracted in the upper to mid third portion. C shows obstruction at the level of the pelvic floors. So you can see there's further ballooning of the proximal urethra and then a nipping in towards the mid to distal urethra. And D is demonstrating a urethral stricture. So once again, there tends to be dilatation above the obstruction, going down to a narrowed caliber urethra. Further findings include those of a urethral diverticulum seen in picture A on the left. So this would be seen more traditionally on a post-void or voiding phase. Urethral stricture again in figure B. Figure C is identifying a kinking of the urethra, so an extrinsic compression due to a large cystocele. And figure E is bladder outflow obstruction secondary to insertion of a mid-urethral synthetic sling or a tension-free vaginal tape, or TVT, which was placed for stress urinary incontinence purposes. Also helpful is the use of nomograms and looking at general diagnostic criteria. The ones that the panel wish to highlight, although there are many that can be chosen from, include the Female Bladder Outlet Index, or the SG nomogram. This looks at the detrusor pressure on urodynamics at maximum flow rate, which is the PDET Qmax, minus 2 times the maximum flow rate measurement, so that's Qmax. If the results of this are a BOO index of less than 0, there's less than a 10% risk of bladder outflow obstruction. If it's greater than 5, the risk is around 50%. And if it's greater than 18, the risk of bladder outflow obstruction in these women is greater than 90%. The Shazazna criteria were also felt to be important, and a Qmax of less than 15 mils per second with a PDET Qmax of greater than 20 centimeters of water were felt to be indicative of female bladder outlet obstruction. And when a review has been done of all the different criteria, it's felt that this, along with fluoroscopy from video urodynamics as highlighted by Nitty's group, showed a good correlation and tend to also be in agreement. The further investigation of female bladder outlet obstruction does include exclusion of an extrinsic cause for the problem, specifically things like a pelvic mass. So it's important to perform either a pelvic ultrasound or MRI to exclude these kinds of pathologies. If you are suspicious of a previously undiagnosed new neurological condition, an MRI of the whole spine plus or minus brain should be performed, and referral to a neurologist. And for specific conditions or concerns such as urethral stenosis, it is important to offer cystoscopy and urethral calibration, so sizing of the urethra. This also gives the opportunity to establish the level of the obstruction and to provide a therapeutic option at the same time, so dilatation of the urethra for true and only for true stenosis is identified. And additional tests can be used where the diagnosis remains unclear or basic treatments that have been tried are ineffective or not tolerated. And we would suggest referral to a specialist or tertiary centre for further investigations, which would include urethral pressure profilography and sphincter EMG, specifically for bladder outlet obstruction conditions. The most important thing in all of this is to correlate your findings, so to take the results from history and examination, cystoscopy, imaging, flow rate, residuals, and video urodynamics, particularly fluoroscopy, all into consideration. There are many causes for female bladder outlet obstruction, and we've categorised them into anatomical and functional. Within the anatomical causes, you can consider these to be iatrogenic. In particular, we've already mentioned stress urinary incontinence or even urethral surgery. Gynecological and prolapse is not an uncommon cause of female BOO. Neoplastic causes causing an intrinsic or extrinsic problem, and inflammation or infection. And we highlight urethral stricture and urethral diverticulum in our document. However, also particularly important would be urethral mucosal prolapse, urethral caruncle, urethritis, and even prolapse of ectopic urethroseals, although these conditions are all fairly rare. Functional causes really fall into three different categories. There is the dysfunctional voiding category, which relates to the non-neurogenic neuropathic bladder, also known as Hinman syndrome, the high-tone non-relaxing sphincter, HTNRS, also referred to as Fowler syndrome or poorly relaxing external urethral sphincter, and primary bladder neck obstruction. So starting with the functional causes. Primary bladder neck obstruction is a description where patients have high pressure, low flow voiding through a closed bladder neck with no abnormal activity at the level of the external sphincter. And it can be due to increased tone, reduced elasticity, fibrosis, and hypertrophy of the bladder neck and proximal urethra. And it's considered a functional problem in some patients as it may be reversible, although there is obviously an underlying anatomical component to it as well. And these patients can present with a whole host of symptoms. Urodynamics tend to show high voiding pressure, a low flow rate, an absence of bladder neck funneling on fluoroscopy, so that bladder neck is nipped in, an absence of significant EMG activity. Going on to dysfunctional voiding, the definition for this is that it is characterised by an intermittent or fluctuating flow rate due to involuntary intermittent contractions of the periurethral, striated and levator muscles during voiding in neurologically normal women. And the predominant symptoms tend to be those of incomplete bladder emptying or urinary retention. And I should emphasise also that this guidance is really specifically looking at non-neurogenic patients. Typical urodynamic findings in this category of women who are thought to have abnormal learned toileting behaviours or can have other traumas that contribute to this condition. Urodynamic findings include a high voiding pressure, a low flow rate, proximal dilatation of the urethra on fluoroscopy as demonstrated by the image at the top, and significant EMG activity in some cases. So it's sometimes described as having a silent kind of pelvic floor EMG, which then has the occasional spontaneous contraction. I think it's a little difficult to distinguish between this on urodynamics alone and high-tone non-relaxing sphincters. So as we said before, it's a matter of correlating symptoms and history and examination. Going on to the final cause of functional bladder outlet obstruction in women, we have high tone non-relaxing sphincter or Fowler's syndrome. It used to be considered a condition of younger women of reproductive age, but in fact it is found in all women of all ages. And there is an association with polycystic ovarian syndrome and endometriosis. Patients can present with obstructive symptoms, idiopathic chronic urinary retention. It is very typically associated with urethral spasm and or pain, particularly when these patients attempt anything urethral, such as intermittent self-catheterization, or they have insertion of urethral catheters. And classically described on external urethral EMG as having complex repetitive discharges with bursts of deceleration during voiding. Although it should be noted that even women with normal voiding in the absence of this condition can also have these findings. Patients do tend, however, to have high maximum urethral closure pressures on UPP. So typical video urodynamic findings in high tone non-relaxing sphincter is that patients tend to have a large capacity bladder. It's often described as atonic with reduced bladder sensation. During the filling phase, things are generally quiet with the detrusor line, and during the voiding phase, there's reduced or absent detrusor contraction with reduced or absent flow. So these patients are commonly unable to complete the voiding phase as they cannot pass urine. The fluoroscopy may demonstrate, or tends to demonstrate, an open bladder neck with narrowing in the mid-urethra, plus or minus ballooning of the proximal urethra. Having sent this out for opinion in the FNUU membership, a very valid point was returned to us explaining that we should be very careful about labelling patients with this diagnosis of HTNRS without considerable period of observation and assessment to, I suppose, rule out and look for other causes, because once a label is applied, patients have a certain expectation and it's quite difficult to undo that. We also felt it was important to add in at this stage the function and psychological disorders that can be associated with idiopathic chronic urinary retention. So the kind of conditions that are associated with these patients with this functional BOO. So in around 25% of patients, they'll also have a functional neurological symptom disorder. And that can be something like non-epileptiform seizures and limb weakness, but also associated with a condition such as fibromyalgia, chronic fatigue syndrome, and irritable bowel syndrome. Depression and anxiety are the most prevalent of the psychological comorbidities, and sexual trauma is considered to be a shared risk factor for both the mental health issues these patients experience and, in fact, the idiopathic chronic urinary retention itself. We've discussed the use of specific mental health questionnaires, and in fact there is a reason, there's many to choose from, but we've suggested one example could be the Patient Health Questionnaire 9, which assesses depression. And the component that the panel and the FNUU membership feel is the most important is that these patients should really have early access and referral to psychological and psychiatric services. So the overview of management for functional BOO is to ensure that urinary tract infection is treated and the patient reassessed, that they are managed at least acutely and potentially long-term with urethral intermittent self-catheterization, and this is always preferable to an indwelling catheter or further surgical intervention for this particular group of patients. We should be thinking about mental health questionnaires and really referral onto mental health services for this group. Biofeedback, behavioural modification and pelvic floor relaxation physiotherapy is helpful, particularly for the dysfunctional voiders. Alpha adrenoceptor agonists such as tamsulosin is particularly helpful for patients with primary bladder neck obstruction and can lead to an improvement in parameters and symptoms in around 50% of women. And urethral dilatation may be considered for primary bladder neck obstruction. But again, Biers panel feels strongly that repetitive treatment should not just be performed over many years. We should be thinking about alternative options or referring on for tertiary referral. If we do refer on to tertiary referral centres to look at alternative options, the options that are available are sacral nerve neuromodulation, which is particularly useful if patients aren't able to tolerate catheters, for dysfunctional voiding, and for patients with high tone non-relaxing sphincter. Patients can be considered for intrasphincteric Botox, that's 50 units, and cutaneous continent catheterizable channels. By that we mean Mitrofanoff, if patients aren't able to urethral catheterize. However, it should also be noted in this group of functional BOO patients, those who find it painful or psychologically have issues self-catheterizing may also have issues doing that through a Mitrofanoff channel. And that group of patients, specifically the high tone non-relaxing sphincter group, can find that this is also not a successful treatment for them. Urethrotomy, incision or resection of the bladder neck for primary bladder neck obstruction is rarely done, but we feel that in the hands of subspecialists in tertiary centres for very selected patients, it is in a reasonable measure. And as a last resort, a diversion of urine in the form of an ileal conduit is an option. Going on to look at anatomical causes of female bladder outlet obstruction, urethral stricture, while not common, is very important, and it describes a symptomatic anatomical narrowing of the urethra that results from fibrosis and scarring, and causes can be idiopathic or iatrogenic. We would advise management should start with a urethral dilatation under a general anaesthetic, having first calibrated the urethra and established this is the true underlying cause. If there is a recurrence, we feel it's reasonable to offer one further urethral dilatation plus or minus intermittent self-dilatation techniques thereafter to keep the urethra patent. However, it should be discussed with the patient that there are other options, including onward referral to tertiary centres, particularly if ISD has been unsuccessful or not tolerated, where there is a role for augmentation urethroplasty, with some groups reporting success rates of between 80 and 94%. And overall, the Biers FNUU Executive Committee feel that multiple repeated attempts at urethral dilatation is not recommended, but there should just be a mechanism in place where you stop and think about what other alternative options could be available and consider referral to tertiary centre. More commonly would be anatomical obstruction secondary to stress urinary incontinence surgery, and that would include operations such as culpar suspension, autologous fascial sling, and whilst they're not in use in the UK currently, many patients will have had a mid-urethral mesh sling. Patients present with voiding difficulty, urinary retention acutely or of later onset, and new onset bladder overactivity. If patients in particular have had a mesh mid-urethral sling, then a cystoscopy should be performed to exclude mesh extrusion, and you should avoid urethral dilatation or urethrotomy in the mesh patients as you risk exposing the mesh and causing further complications. Management options for these patients, at least acutely, would definitely be urethral CISC or an indwelling catheter where this is not feasible, but you would hope that that wouldn't necessarily be the long-term solution unless the patient wished to pursue that, and that you should discuss with them the alternative options. And at this point, we would advise referral to a tertiary centre. For a mesh sling, there can be division, removal of the vaginal portion, or complete removal of the mesh sling. For culpar suspension, if it's an early onset, there's some ability to remove a suture or two, or if it's a later presentation, reversal or taking down of the culpar suspension. And with an autologous fascial sling, if there are early problems with retention or voiding dysfunction, early release of the suture is possible, but in delayed presentations, it means urethrolysis or removal or division of the sling. And it would be common practice, particularly after mesh slings or natural slings, to consider insertion of a Marshall's labial fat pad flap in preparation for any further stress urinary incontinence that's anticipated. Because these patients should be warned that if you are undoing or dividing tape or mesh, that they are at risk of recurrent stress incontinence. But not only that, they are at risk that even if we do this, they may not establish normal voiding again. And if they have any further stress urinary incontinence surgery, they are at risk of developing urinary retention again. The final category that we wanted to talk about in the remit of female voiding dysfunction is that of detrusor underactivity, which is defined as a contraction of reduced strength and or duration, resulting in prolonged bladder emptying and or failure to achieve complete bladder emptying within a normal time span. And patients present with a slow urinary stream, hesitancy, straining to void, with or without a feeling of incomplete bladder emptying and sometimes with storage symptoms. Is reported to affect 12 to 45% of women. It's more common in older ladies, and complications of this do include recurrent UTIs and urinary retention. And causes of detrusor underactivity in women, again, is quite widespread. Other than neurological causes, which we don't really cover in this consensus document in great detail, there are risks with any tablets that calm down or relax the detrusor of the bladder. So by that, it's typically drugs with anticholinergic effects, opiates, Botox, and gabapentoids, including pregabalin. But other causes include primary detrusor failure and overdistension injury of the bladder, which is caused by unrecognised or untreated urinary retention. The assessment of detrusor underactivity is very similar to before, in that we should be actively investigating and identifying the underlying cause where we can. We should stop or change drugs that may be contributing to the urinary retention and then reassess the patient, and perform a full clinical assessment, including a neurological assessment. Urodynamics can be performed to help make the diagnosis, and typically patients would have a low detrusor voiding pressure and a low flow rate where they're able to void, although many of us will recognise that these patients commonly are unable to void. And it can be difficult to distinguish between detrusor underactivity and conditions like high tone, non-relaxing sphincter on urodynamics alone. And it's essential again to correlate the clinical presentation and the investigation findings to make your diagnosis and support it. The management of detrusor underactivity in women is to advise urethral intermittent self-catheterization, and where this isn't possible, to consider a long-term indwelling suprapubic catheter where all other options are either not appropriate for the patient, or the patient has decided they don't wish to pursue for anything more invasive. Do consider referral to a tertiary centre for consideration of a continent cutaneous catheterizable channel such as a Mitrofan or a Monti, if urethral CISC is not possible or not tolerated. And in selected patients, sacral nerve neuromodulation can be actually very effective, although it tends to be most effective for the patients with detrusor underactivity, which is associated with high tone non-relaxing sphincter. So in summary, the FNUU Executive Committee has gone through several rounds of peer review and review by BAUS FNUU membership, and again at this meeting today, in order to take your comments and to provide a document that is suitable to guide UK best practice for female voiding dysfunction. We've concentrated on trying to provide a framework that's useful and practical for the management of bladder outlet obstruction due to anatomical and functional causes in women, and also the cause of detrusor underactivity. We welcome your questions and your comments, and are very happy to refine the guidance prior to submission to BAUS Council. Thank you very much.
Hi, I'm Richard Parkinson, and welcome to this session. Asad, Ali and I have been asked to talk about the management of long-term catheter problems. As you know, this is a common issue, and the FNUU section have developed a consensus document to help practitioners troubleshoot the common problems encountered in clinical practice. And we'll use this session to go through that. So we're going to look at a couple of different scenarios. The first scenario is this frail man with multiple comorbidities who's had a long-term catheter inserted for urinary retention and has failed a trial without catheter. He's come back to clinic because of catheter spasms, blockages and bypassing of his urethral catheter. So let's consider the management of this common scenario. The first consideration is whether there is an alternative to his catheter. The recently published consensus document from Biers on long-term catheter management concurs with NICE that a long-term catheter should be the last resort and other methods of management are often preferable.
So, Richard, assuming that other options have been ruled out, we've got a patient with bypassing. How would you go about troubleshooting the underlying cause for that?
Well, in a patient with catheter bypassing, the history will often give us a clue as to the underlying cause and therefore the correct treatment. Firstly, we need to decide if it's blocking or due to spasms or something different. Bypassing that happens after a period of reduced drainage suggests that the catheter blockage is a likely cause. It's important to think about the different possible etiologies for catheter blockage. Simple steps such as checking the catheter drainage system for kinking comes first. An embedded catheter may be released by manipulation of the catheter or elevation of the bag for a short period to reduce the siphoning effect. And a flip flow valve allows the bladder to fill and empty, and the catheter tip is then less likely to become chronically embedded. These novel catheter designs have been developed to prevent the embedding of a catheter tip. The general concept being to protect the urothelium from the drainage holes. Now, although these may reduce the embedding of the tip in the urothelium, there's sadly very little published evidence to confirm their efficacy, either for blockages or for pain. Luminal debris is a common cause of blockage. Bacterial colonisation is certainly a factor, although this is inevitable and probably unavoidable in long-term catheter users. Initial lifestyle measures should always be explored, of course. Investigations should be considered where the problem is more severe, however. The use of medications to reduce bacterial colonisation is controversial. There's little or no evidence that these will reduce either catheter blockages or catheter-associated UTI. However, some patients and clinicians have reported some success.
So, Richard, what are your thoughts on the use of these bladder washout products?
So, catheter maintenance solutions are commonly used, but these are not washouts as such. A relatively small amount of fluid is instilled and then allowed to drain by gravity. There's no agitation of the bladder debris, and these are probably not effective in addressing the buildup of heavy sediment. There may be a role in preventing incrustation of catheters with these products. However, a recent Cochrane review did not find sufficient evidence that they did more good than harm. Bladder washouts are commonly used to clear debris or blood clot from the bladder. The fluid is instilled so as to agitate the contents of the bladder and then aspirated to clear the sediment. This has fallen out of favour in community services in recent years due to a perceived risk of harm or infection. However, there is no evidence that bladder washouts cause infection, and the possible reduction in blockages and unscheduled catheter changes is likely to be beneficial. The efficacy of this treatment has not been studied systematically, however. Although sterile commercial fluids can be used, tap water that's been boiled and then thoroughly cooled is perfectly adequate. New technologies are being promoted to reduce catheter-associated UTIs and blockages. Inflating the balloon with triclosan aims to reduce colonisation, biofilm and encrustation. The cost of this is £4.80 per syringe. The SAT device causes vibrations of the catheter to reduce adhesion of the bacteria. And this device costs about £500 and will last about 2 years, but the actuator costs a further £80 and is changed monthly. Neither of these have good quality published evidence to support their efficacy at this time, and these are not routinely recommended pending future research.
So, Richard, what are your thoughts about bladder spasms?
Okay, well, yes, another common cause of catheter bypassing is bladder spasm. It often causes pain additionally. Simple dietary advice and treatment of constipation are always recommended. The efficacy of anticholinergics for treatment of bladder spasms is well established. Although beta agonists have not been investigated for this investigation, it would be logical that these would be effective given their known effect on detrusor contractions. Botox injections are often effective. Unfortunately, the duration of action is probably less than we see with overactive bladder patients. And I tend to use a higher dose of, say, 300 units, as there are no concerns about urinary retention in this group, of course. Patients with long-term catheters will commonly have intermittent problems with infection, blockages, spasms, and bypassing. And while these are accepted side effects, patients with severe and frequent problems merit further investigations. Investigations should also be considered in patients with hematuria or a recent change in their catheter-associated symptoms. Cystoscopy is often the investigation of choice. A final thought on leukoplakia, i.e. keratinizing squamous metaplasia. This is a pre-malignant condition that mandates long-term surveillance. It's characterized by white patches on the urothelium and should not be confused with non-keratinizing squamous metaplasia in women, which is commonly seen around the bladder neck and is of no consequence at all. For leukoplakia, annual GA cystoscopy with biopsy is recommended by the Bowes consensus document. Leukoplakia often develops as a result of chronic inflammation. It can be seen in patients with long-term catheters and also those with chronic urine infection.
Yes, so urine infections are quite a common and important complication of long-term catheter use, and that brings us quite nicely onto the next case. So the second scenario is a case about a 21-year-old male university student who's got a T4 incomplete paraplegia. He suffers from recurrent UTI about every month or two, and it's interfering with his studies, as each time he has to take about 2 or 3 days to recover. Initially, he was managing with ISC, but he's had to change to a urethral catheter because he was finding ISC difficult at university.
Oh, okay. So how does catheter-associated UTI occur and how should it be managed?
So catheter-associated UTI occurs at a rate of 3% to 10% per day, or around 50,000 episodes per year. It's one of the leading causes of hospital-acquired sepsis, and around 8,000 episodes of catheter-associated blood sepsis infection, CABSI, occur per year. The total economic burden, including direct hospital costs and loss of quality life years, is between 150 and 330 million pounds. First thing to say is that urinary catheters are readily colonized, and by about a month, all catheters are colonized by bacteria that form a biofilm. So we'll always find bacteria, and the recommendation, therefore, is not to treat asymptomatic bacteriuria. The key is only to treat when the patient's symptomatic, and i.e. has things like cloudy, smelly urine, blood in the urine, increased bypassing, pain, fever, confusion, fatigue, etc. It's not always straightforward, particularly in elderly and neuropathic patients. So there needs to be a high index of suspicion. The bacteria actually get in through 2 routes. There's the intraluminal acquisition of organisms, which is usually associated with endogenous organisms, i.e. bacteria.
So what about suprapubic catheters? Would they help?
So in terms of suprapubic catheters, there has been a Cochrane systematic review, and this showed insufficient evidence for reduction in symptomatic UTI. There was, however, less bacteria and less pain. From a Bowes recommendation point of view, an SPC is obviously recommended, but usually for other reasons, the most important being prevention of long-term urethral and sphincteric damage by a urethral catheter.
A suprapubic catheter is a useful alternative to urethral long-term catheter. There are a variety of advantages, but there are also limitations and risks associated with choosing an SPC. As with anything, patients need to be counselled about the alternative treatment options. Firstly, many patients find an SPC more comfortable and there may be less risk of bladder spasms. However, some patients find the SPC to be very painful for reasons that are not always obvious. Suprapubic catheters prevent the development of urethral erosions, especially when there's a reduced sensation, such as in neuropathic patients. SPC also reduces the risk of chronic bladder neck dilatation in women, and there's much less chance of expulsion. The SPC route allows a much larger catheter to be used. We usually use a size 20 or higher. This probably helps to reduce blockages, but there's a lack of definitive evidence for this. The SPC will not, however, prevent or reduce UTIs, stones, or prevent the loss of capacity experienced by many patients with long-term free drainage. The BAUS recommendation 9 in the consensus document is to use a suprapubic catheter rather than urethral when it's safe to do so. SPC insertion is usually straightforward, but it's not without risk. Trocar kits make this a minimally invasive procedure. However, the main consideration is the risk of bowel injury during insertion. This is an uncommon but potentially devastating surgical complication, and it's more common where there's been a history of lower abdominal surgery, even laparoscopic surgery. Although ultrasound scan is a useful technique for identifying interposed bowel loops, this can be technically challenging, even for experienced sonographers, and should only be undertaken by those who have sufficient training and experience to perform this confidently. Ultrasound is performed synchronously with the needle insertion in real time. A previous ultrasound or CT report may not be a reliable indication of bowel interposition. Open cystotomy is an alternative approach, but this is more invasive and therefore associated with other risks, not least wound infection. The revised BAUS SPC guidelines will be published imminently in the BJUI. In conjunction with the BAUS consensus document on catheter use, we hope this will provide a comprehensive troubleshooting and best practice advice for long-term catheter management. Thank you.
Hello everyone, my name's Chris Harding and I'd like to present to you the results from the BAUS bladder outlet obstruction audit. Credit must go to the entire membership, and on behalf of the BAUS Audit Steering Group led by Mr. Andrew Dickinson, we would like to thank you all for ensuring delivery of a successful project. This audit represents the first of a new style of BAUS audits, which are a move away from the traditional, more procedure-based audits which fed into the publication of consultant outcomes. The Audit Steering Group was initially convened in 2018, and we felt a move towards more topic-specific projects would reinvigorate the membership's interest in clinical audit and provide significant drivers to improve practice at both a local and national level. The acquisition of patient-relevant data was one of our primary aims, and our aspiration was that this process would drive important future clinical research. The selection of our first audit project was based on three main domains, which were importance, clinical care, and practicality. As a result, we selected a core urological condition, bladder outlet obstruction, for our first project, with the hope of large-scale data capture and widespread participation. In terms of process, we contacted all audit leads in each urology unit in the UK in the autumn of 2019. We informed them that a retrospective audit was planned and the data required would come from a specified time frame, which was November of 2019. The data would be entered in March 2020 to allow for sufficient follow-up data to be captured. Due to the coronavirus pandemic, the window for data entry was extended slightly, given that some urologists were redeployed during that time. We avoided the collection of patient identifiable data and utilized the JotForm data platform, which appeared to work very well. The data sets we collected are shown on this slide, and as you can see, the audit comprised 36 questions, which covered several domains. We recorded information regarding participating hospital, preoperative patient characteristics, procedural details, and postoperative progress. The selection of these domains allowed us to analyze the acquired data in terms of safety, efficacy, and accessibility. In total, 1,456 cases were entered in March to June of 2020, with 105 urology units participating. On average, 11 cases were collected per participating site, and the highest number of cases entered at any site was 63. Our chosen method of cross-checking data capture was via hospital episode statistics. HES data collected from England revealed that 1,620 bladder outlet procedures were coded in the month of November 2019. Over the same time period, our audit captured 180 cases from England. Therefore, we estimated that our overall data capture rate was around 70%. The participating BAUS membership should be commended on this achievement, and the success of this audit is solely due to the efforts of everyone who participated in the audit and entered data. And on behalf of the Audit Steering Group, I would like to extend our sincere gratitude for your efforts. A summary of the preoperative information is shown on this slide. The average age of men undergoing bladder outlet surgery was 72, and the vast majority had the findings from digital rectal examination recorded in their medical notes. 38% of patients had previously had urodynamic evaluation, yet only 20% had completed a frequency volume chart. Given that around 40% of our patients exhibited either acute or chronic urinary retention and wouldn't have been able to complete a frequency volume chart, the corrected figure for frequency volume chart completion in those who could void was 28%. In roughly 1 in 5 cases, the bladder outlet surgery was a redo procedure, and in approximately 1 in 10 cases, the preservation of sexual function was noted as a factor in the decision-making process regarding the type of procedure performed. The majority of procedures were performed by a consultant, and this includes prostate artery embolization procedures, which were almost exclusively carried out by consultant interventional radiologists. Where a specialty trainee performed the surgery, they were mostly supervised by a consultant in theatre. In terms of the distribution of bladder outlet procedure, TURP constituted around 60% of all surgeries. Around 2/3 of the TURPs were bipolar. The second most common procedure was holmium laser enucleation of the prostate, representing around 10% of all bladder outlet surgeries. Other recorded procedures included Urolift, 7%, green light laser prostatectomy, 6%, Retsum water vapor ablation, 5%, and prostate artery embolization, 4%. Bladder neck incision was performed in around 5% of patients, and only 2 open prostatectomy procedures were performed in the UK in November of 2019. Examining the indications for surgery revealed around a 55-45 split in terms of symptoms versus urinary retention. The vast majority of men with troublesome lower urinary tract symptoms had previously failed medical therapy with either alpha blockers or 5-alpha reductase inhibitors. In keeping with previous large series of bladder outlet surgeries, around 12% of our patients had an underlying diagnosis of prostate cancer. 3% of our cohort had concomitant procedures for bladder stones. In terms of more in-depth analysis of our data, I will present the findings separately for those with low urinary tract symptoms and those in retention. In order to give you a bit of further insight into the range of procedures performed, particularly according to indication, we looked at the distribution of procedures for men in retention. As you can see from this graph, the HOLEP group contained the highest proportions of men in retention, followed by green light laser prostatectomy and bipolar TURP. Those undergoing Urolift procedures, Retsum, bladder neck incision and prostate artery embolization had statistically significantly lower proportions of men in retention in those treatment groups. Conversely, there were statistically significantly higher proportions of men in retention in both the HOLEP and bipolar TURP groups. I'll now concentrate on the cohort of men who underwent bladder outlet surgery for the specific indication of troublesome low urinary tract symptoms. We looked at specific differences in terms of symptom severity, with a definition of severe symptoms being an IPSS score of 20 or greater. We looked at those with large prostates, which were classified as prostate size of 80 cc's or more. And we also looked at those with severe comorbidity, which was defined as ASA3 or greater. There were no statistically significant differences in the proportions of men with severe symptoms undergoing the various surgical procedures analysed. The HOLEP, green light laser, and prostatic artery embolization groups contained statistically significantly higher proportions of men with large prostates. Conversely, significantly lower proportions of men with large prostates underwent urolift or Retsom procedures. Finally, the group of men undergoing a Retsom procedure contained a statistically significant lower proportion with significant comorbidity. We also looked at safety metrics in men undergoing bladder outlet surgery exclusively for lower urinary tract symptoms, and found that men undergoing green light laser procedures were more likely to have a postoperative infection requiring intravenous antibiotics. We found that men undergoing HOLEP were more likely to require a blood transfusion or return to theatre. In terms of other complications, there were no significant differences between procedure types, apart from readmissions, where we found that men undergoing monopolar TURP were more likely to be readmitted after their surgery than those who had other bladder outlet procedures. Within our cohort of 1,456 men, a subset of patients had paired pre- and post-op data for symptom score, urine flow rate, and post-void residual volume. This subset of patients represented between 8 and 13% of the whole cohort, as shown in the graph on this slide. It must be noted that this is, of course, non-randomized data, and therefore any efficacy comparisons are limited. In terms of improvement in IPSS score, there were no significant differences between procedure types, although there were insufficient data to include green light laser and bladder neck incision in this analysis. Looking at bother score, a similar finding was made. Analyzing pre- and post-operative uroflowmetry data showed that men undergoing urolift procedures exhibited lower levels of flow rate improvement in the short term after their surgery. There were no significant differences across procedure types when analyzed for improvement in residual volume. Further efficacy parameters were analyzed and are shown on this slide. The waiting times for bladder outlet surgery were roughly equal across all procedure types. We found that men undergoing prostatic artery embolization or urolift procedures did not usually have a catheter inserted. Those who underwent HOLEP or BNI operations would on average have catheters removed after 1 day, whilst men with TURP procedures would usually have the catheter removed after 2 days. In those undergoing green light laser prostatectomy, the median time to trial removal of catheter was 3 days. And for the small number of patients undergoing Retsom procedures, the average time with a catheter in postoperatively was 7 days. In terms of the percentages of men who failed their first trial without catheter, there were no significant differences between the procedures analysed. Our results show that the vast majority of men had an overnight stay in hospital following a bladder outlet procedure, with the exception of those undergoing urolift, Retsom, and prostate artery embolization. There were no significant differences in the percentage of men who retained a catheter at 3 months when the data was analysed by procedure type. Moving on to those who underwent bladder outlet surgery for acute or chronic urinary retention, we carried out analysis on the 4 main procedure types for this indication, which were bipolar TURP, monopolar TURP, HOLEP, and green light laser prostatectomy. Looking at the baseline data for these patients revealed that HOLEP group had significantly lower proportions of men in chronic retention, which was defined by a residual volume of greater than 1 litre. The bipolar TURP and HOLEP groups had significantly higher proportions of men with larger prostate glands, again defined as a prostate volume of greater than 80 cc's, and a history of urinary retention. Conversely, the group of men in retention undergoing monopolar TURP were proportionately less likely to have larger prostate glands. Finally, in those undergoing monopolar TURP, there were proportionately more men with severe comorbidity. In those undergoing HOLEP operations, there were proportionally less men with an ASA of 3 or above. Moving on to safety metrics, for those men in urinary retention, we found that those who had a HOLEP operation were less likely to have a post-operative infection requiring intravenous antibiotics, and those undergoing monopolar TURP were more likely to require a blood transfusion post-operatively. All other safety metrics, such as return to theatre, Clavian 3 or 4 complication rates, and percentage of men requiring readmission, were similar across the 4 main procedure types. Looking at measures of efficacy, we found that men in urinary retention undergoing holmium laser enucleation of the prostate waited longer on average for their procedure. Those having HOLEP procedures were, however, more likely to have an initial successful trial removal of catheter, whereas those undergoing monopolar TURP were more likely to fail their initial trial of void. For those men in retention who underwent one of the 4 major procedures analysed, the median length of stay was 1 night for holmium laser enucleation and green light laser prostatectomy, and 2 nights for both monopolar and bipolar TURP. Looking at those men in retention who still had a catheter in place at 3 months following their surgery, we found that those who had undergone HOLEP operations were less likely to retain a catheter at that stage. Although so far I've presented an overview of the national data, this slide shows how we fed back information to individual units. We reported the total number of cases submitted and gave details regarding the average age of the patients, indications for surgery, and the procedures performed. We then concentrated on metrics that we felt would be useful at a local level, such as waiting times for those who are catheterized and not catheterized. In addition, we were able to report compliance with current guidelines in terms of number of patients with a validated symptom score assessment, a digital rectal examination performed and documented, and a frequency volume chart completed alongside a post-void residual volume documented. We were also able to provide information regarding the proportion of day cases carried out, the number of patients failing an initial trial of void, and proportions of men who were catheter-free at follow-up. In terms of safety data, we also included detail regarding transfusion rate, reoperation rate, post-operative infection rate, and readmission rate. This type of feedback is an example of how a national audit can be useful at a local level and reinforces the point that units will acquire more useful information the more data sets they enter. I hope I've demonstrated that the first of the new style Biers audits was not merely a national overview of practice, but allowed for provision and feedback of unit level data, which could be used to shape local practice. My last 2 slides will sum up the overall conclusions from the national data. Many of our analysis included only small numbers, and given that this is audit data, it must be remembered that it is non-randomized data. This is particularly pertinent when considering safety and efficacy data I presented earlier, which of course may be affected by selection bias. It was striking that preoperative data analysis showed roughly 40% of men had had urodynamics, whilst only 20% had completed a frequency volume chart. This is despite almost all national and international guidelines recommending the completion of a frequency volume chart in men with low urinary tract symptoms. Our data revealed a rough 55 to 45 split in terms of indication for surgery between bothersome low urinary tract symptoms and urinary retention. Men undergoing HOLEP and bipolar TURP had the highest proportions of men in retention. Analysing the range of procedures performed across the whole cohort revealed that bipolar TURP is now the most commonly performed procedure for bladder outlet obstruction. Analysing the group of men who underwent bladder outlet surgery for bothersome low urinary tract symptoms revealed that the groups undergoing HOLEP, green light laser, prostatectomy, or prostatic artery embolization contained a higher proportion of men with large prostates. Overall, the new minimally invasive procedures appeared to perform very well in terms of both safety and efficacy. It must, however, be remembered that follow-up in this audit was 6 months at most. It remains to be seen whether these newer procedures have the long-term durability of more traditional procedures such as TURP, but the literature from elsewhere would suggest that this is likely to be the case. It was evident from our data that the majority of men undergoing bladder outlet procedures would spend at least one night in hospital. Therefore, it appears that day case bladder outlet surgery is still aspirational for most units. Finally, I would like to point out that we have collected an enormous amount of data during the course of this audit and have really only scratched the surface in terms of our analyses. We would welcome any of the BAUS membership to approach the audit steering group should they have any ideas for further analyses, as after all, this is your data. Many thanks again for your enthusiastic participation in this project and for your attention during this presentation. Thank you.
Thanks very much. Welcome, everyone. I'm Rob Calvert from Liverpool. I'm going to present on behalf of the BIOS Audit Steering Group and also the Endourology section the next of the BIOS snapshot audits. This is the renal colic audit. So why are we doing this? Well, principally to improve patient care. This is the second of the new types of audits. You've probably just heard Chris Harding talk about the bladder outflow obstruction audit. And the aim of this is to move away from the major procedure registries and to get audits that are more patient focused and that look at lots of the different steps in the journey, maybe more relevant to a patient rather than whether your surgeon has a 90% stone clearance rate with a ureteroscopy or an 85% stone clearance rate. The fact that the patient has had a stent in place for 4 months or doesn't get the right analgesia when they come into A&E and have a lot of vomiting. So we're looking at unit level data, and feedback is a very important thing, and that's something that there's going to be a big focus on. The idea is to identify issues that can be improved in the unit. We now have some evidence-based standards, and I did a talk in the endourology update section yesterday on some of those quality standards. We also have some benchmark standards from some of our previous procedure registries. And the new audit has been designed to be easy to use. The section has put quite a lot of work into trying to design an audit that is important to patients, that is a common procedure, that addresses areas where we believe that there are differences in practice, and that avoids data that we can get from other sources. We look at a variety of measures of patient safety, patient efficacy, and also access to treatment, which is very important for patients. And when we're assessing these audits, we always have to have practicality in mind and how easy we can get feedback. There are a number of audit assessment criteria here that are scored by the audit steering group, and any BIOS member can submit. There is a BIOS audit proposal form on the website, and we would encourage members to have a look at this. So for the renal colic audit, who are we looking at? Well, we're looking at those patients coming in with renal colic and who have a confirmed stone in either the ureter or the renal pelvis. We are excluding patients with bilateral stones, although it doesn't matter if there is a stone in one or both kidneys, but it is the management of the ureteric stone that we are focusing on. So when are we measuring? Well, we've already started. So it is this month, November 2020. Although don't worry if you haven't done anything yet, because the data is recorded retrospectively in March next year, 4 months' time. The section committee and also the audit steering group did give quite a lot of thought to the timing of this, because we're mindful that COVID is spreading around the country. Ultimately, it was decided we didn't wish to delay things further. There are a number of other audits in the pipeline, and COVID may be with us for some time. And some of the changes that COVID has made us introduce are very relevant to stone practice. Of course, we will have to bear this in mind, and units will bear this in mind when they are interpreting the data that comes from this. Your departmental audit leads will already have received some emails, and there's also a link at the end of this talk to the Biers website, which has this letter on it that goes to your clinical information department to help you identify the patients. A lot of units have their own methods of recording patients who come in with renal colic, but this should help you identify the patients, although you will have to go through some of the CTs to exclude those who didn't have a stone, because they may be included with this sort of audits, this sort of search. And we're using the JotForm audit platform again. This is what we use for the bladder outflow obstruction audit. It's been designed to be as easy to use as possible, and we were delighted to get 70% case ascertainment for the bladder outflow obstruction audit, which is a real credit to the Biers membership. The platform has a series of drop-down menus, easy to input dates and times, and a number of buttons to press. And we tried to design the questions to get the most bang for our buck. This is designed to be completed in 5 to 10 minutes per patient. And we're asking questions aligned with some of the quality standards, like what was the first line analgesia? Was it a non-steroidal? Was a CT scan performed within 24 hours of presentation? If you missed the talk yesterday, these are the 5 quality standards that NICE have produced. And this audit now is linked into quality accounts, which means it's mandatory, and it will be looked at by some of the service providers and hospital inspectors like CQC. We also will be looking at measures of sepsis investigation where appropriate. And this is one of the main branching point questions. So for these patients, what was the initial management choice? Conservative management, primary lithotripsy, primary ureteroscopy, temporizing ureteric stent, nephrostomy, or other. I'm showing a few of the questions, not all of them. Outcome of the first appointment following conservative management: has the stone passed? Is the patient going to ureteroscopy? Is the patient going to lithotripsy for further imaging or for a further trial of conservative management? The JotForm has conditional logic, so you don't go through every question. It depends, the questions you get asked depends on the choices you make. Outcome following the first session of lithotripsy: stone cleared, rebooked for a second treatment, unable to target stone, or booked for ureteroscopy. Outcome following primary ureteroscopy. We also ask, has all the stone treatment been completed at the time of form completion, including removal of JJ stent? We anticipate that these questionnaires will be completed at about 4 months. So that in itself is an outcome measure if this ureteric stone is still there, that's sitting beside a stent. And also we ask how many treatment episodes in total were required, including stent removal. We look at complications, including UTI, sepsis, ureteric injury, readmissions with colic, readmissions with stent symptoms. And part of the quality standards are the very simple questions of, has the patient had a serum calcium measured, and have they had appropriate diet and fluid advice? This is the list of all the questions. You don't go through them all, it depends what boxes you tick. And the platform can be used on Windows computers, on Macs. It can be used on your phone, Android or Apple. It's pretty robust. It seems to work with some of the quite older versions of Internet Explorer. So in simple terms, you identify the patients, you submit the data. Hopefully you'll be getting the feedback towards the end of next summer, and then you analyze the data from your unit's perspective and see what changes need to be made. We've chosen a whole range of outcome measures across safety, efficacy, and accessibility. and a number of these are tied in with the evidence-based quality standards. So who will look at this data? So it's not just healthcare professionals, but also service providers will look at this because they have a responsibility to try and improve care to help you meet these standards, and commissioners too. This is about helping urologists help patients. This is about making sure you get the adequate resources you need to have to do what you need to do. Can you not get access to hot litho? Well, hopefully this will be a tool to help you get that. Can you not get into theatre to laser stones primarily because no one gets laser trained? Well, this is another tool for that too. And as Chris has just presented, there will be a lot of national level data that comes from this. You should get some benchmark real life data for a whole range of metrics. This will be the first large survey of the real life logistics of colic patients around the country. There's evidence to push for better stone treatment resourcing right across the country too, hopefully. And we should get some real life comparative safety and efficacy data for different treatment paths. So for some more information, here are some links. Also, hopefully there will be some information on Twitter relating to this audit over the coming year. Thank you.